Hello. Hello friends, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shonali Chandra, and in today's session, we'll be having a case-based discussion on adenomyosis, and we'll discuss it with the help of a case scenario. I've highlighted my reference code here, which is SHONALI. So if you take the Unacademy platform subscription, you can avail this code, use this code to avail a 10% discount on your subscription package as well. You can also download the Unacademy Learning app for further notifications and to make your journey easier. You'll get daily live classes where you can chat with your educator, engage in doubt clearing sessions, and get your queries solved there and then. So it's like a live classroom experience. The courses are structured keeping in line with the latest NEET PG syllabus. There are also live tests and quizzes on the platform which will help you evaluate your performance as you go along. And most importantly, one-time subscription gives you unlimited access, so you can watch all the live sessions from all the faculties who are active on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices at the time of your own choosing. And there are top educators who are associated with the platform. All 19 subjects which we need to prepare for our post-grad entrance exams, they are covered. And every now and then, comprehensive batch courses as well as short duration crash courses, they keep getting launched. So you can check out the ongoing courses in the platform as well. And there's a new subscription package which is called the Iconic subscription, which allows you to access Unacademy and Prep Ladder subscriptions at the same time. And if you choose the Iconic subscription, you can take one for 12 months, 18 months, 24 months, or 36 months duration. And if you subscribe using the code that is SHONALI, then you can avail an additional 10% discount on your subscription package as well. And moving on, talking about the plus subscription for the NEET PG syllabus. So you can choose a subscription package depending on your need and requirement. So let's say you are targeting the upcoming exams and you want a crash course, then you can take the 1 month subscription package. If you're targeting the next exams, then you can take the 12-month subscription package. It will give you enough time to go through all of the sessions and will leave you time in the end to revise as well. And it turns out to be more economical also in the longer run. And if you're a third year or final year MBBS and want a slower pace of preparation, or if you're working and you're juggling hospital duties and classes and clinics and schedules at the same time altogether, you can take the 24-month subscription. It turns out to be far more economical in the longer run. And if you subscribe using my code that is SHONALI, then you can avail a 10% discount on your subscription package as well. And to tell you further what are the upcoming sessions on these special classes. So these are special classes, live classes, free classes which are taken on the Unacademy platform. And tomorrow on 29th of November, 8 p.m., I will be talking about vulval cancer in that session. That's an upcoming session, 29th of November, 8 p.m. You can also check out the previous special classes, free classes, which I've taken on the platform earlier. And once you subscribe to the platform using my referral code SHONALI to help you get a 10% discount, you can also find the capsule courses where detailed discussions of topics are undertaken. So there's a capsule course on reproductive gynecology, on high-risk pregnancy, on gynae oncology, as well as on labor and its complications. So you can check these plus courses out as well on the platform. So coming back to the session at hand for today, we are discussing a case scenario of adenomyosis. So good evening, Raja Thipan, and good evening everybody else who has joined in. And Monica, Sanam Aftab, Aisha Nikhat, good evening to you guys. So let's just quickly revise what adenomyosis is, right? So adenomyosis is, again, like yesterday we were considering the Palm-Cohen classification or the Palm-Cohen differential diagnosis of abnormal uterine bleeding in the reproductive age group, and we came across the A, which stands for adenomyosis. Now, it is again a disease mainly confined to the reproductive age group, which deals with the presence of endometrial glands plus stroma inside, embedded deep within the myometrium. So endometrium is supposed to be the endometrial lining of the uterine cavity, right? Now, there is a certain situation when those endometrial glands and stroma in turn they move into the uterine myometrium, and that condition is called as adenomyosis, presence of endometrial glands plus stroma deep within the myometrium, right? Now, the other important thing to note here is that it has been often postulated that with repeated childbirth, right, with repeated childbirth and some tears that take place in the endometrium, the endometrial tissue can seep into the myometrium and get buried and embedded there. So it is more common in multiparous women. So it has traditionally been, yes, more confined to multiparous women who've completed their families and who are in the age group of 30s and 40s. But now it is not uncommon to see adenomyosis even in younger women as well. So yes, it is more common in multiparous women. That doesn't mean that it can never happen in younger or nulliparous women as well. Now, moving on further, another very important aspect of this adenomyosis is that, around these deposits of endometrial glands, right, each month when, bleeding takes place, you see the endometrium is shed off, right, and fresh endometrium is built up each month. Now, what happens is that when during the menstrual cycle, what happens is that these deposits of endometrial tissue deep within the myometrium, they also bleed. Now, for that bleeding, there is no outlet. It is happening here. So inflammation is triggered in the layers of the myometrium. Inflammatory mediators are released, which also triggers the hyperplasia of the surrounding muscle layer, right? So this is your endometrium deposit, which is present inside the myometrium. And around these deposits, what develops is a layer of myometrial hyperplasia, right? So that in together, in a nutshell, what it does is it brings about diffuse enlargement of the uterus, right? So the uterus is diffusely enlarged, and most of the times the enlargement is limited to around 12 to 14 weeks in size. It does not get to dramatically huge uterine sizes. So there is diffuse globular enlargement of the uterus, usually about 10-12 weeks in size. Now, the other important thing to note here is that this condition also predisposes to abnormal uterine bleeding, right? So the uterus is not normal here. The endometrium has been moved inside the myometrium, and then there are myometrial hyperplasia is there, inflammation inside the myometrium is there. So the contractility of the uterus is affected, right? So it leads to heavy during periods. So these are the two very, very characteristic features of adenomyosis: abnormal menstrual bleeding along with painful menstruation, along with dysmenorrhea that we call it, right? So moving on further, let's have a look at the particular case scenario which I'm about to discuss with you. And we will follow the same principles which we highlighted yesterday: how to evaluate women with abnormal uterine bleeding. Thorough history taking, clinical examination comes first, and then based upon these findings, we are coming to a differential diagnosis, and then we are performing investigations to find out the cause. Now, there's a 45-year-old multiparous woman who comes to the gynae OPD with complaint of heavy menstrual bleeding. Now, the next step is to ask her the LMP, and the next step is to find out the pattern of the abnormal menstrual bleeding. So her last period, she says, was 3 weeks ago. You inquire further about the pattern of bleeding. She tells you that she has regular cycles, right? So there are no irregular cycles, right? Neither there is history of oligomenorrhea followed by heavy bleeding. So unlikely anovulatory cycles, right? So cycles are regular, about 28 to 30 days in duration, right, lasting for 7 to 8 days. So she has a bleeding episode which lasts for 7 to 8 days. That is quite excessive, isn't it? So yesterday we said that normal menstrual pattern is when the bleeding lasts for any time between 2 to 8 days. So she bleeds for 7 to 8 days with heavy bleeding, passage of clots, soaking 3 to 4 pads in a day. So it has been established that she has heavy menstrual bleeding, right? We established that she has heavy menstrual bleeding, and we also established that it is heavy in amount as well as in duration, right? Now moving on further, she also suffers from severe pain during her menses. Now all women have some or the other amount of spasmodic dysmenorrhea. Some pain during menses is there happening to most of the women, but when I say spasmodic dysmenorrhea, it is something that is physiological and normal, right? So the pain begins on the day of menses, right? And then the pain also improves once the flow starts, right? So the pain lasts for a day or two for most of these women. Now this particular pain in this woman begins about 2 days prior to the blood flow, for which she has to take antispasmodics and analgesics, and that pain will last for the entire duration of the menstrual blood flow. Now this is what we call as congestive dysmenorrhea. This is what we call as congestive dysmenorrhea. So we have established that she has heavy menstrual bleeding along with congestive dysmenorrhea, right? And this has been going on for the past 4 years. So her complaint is of long duration. For past 4 years, her menstrual cycles have been heavy, troubled with congestive dysmenorrhea. So what are the differential diagnoses that I'm considering? I'm considering all the differential diagnoses which we discussed yesterday. The polyps I'm considering, adenomyosis I'm considering, leiomyoma I'm considering, possibly malignancy I'm considering, right? And the Cohen group of disorders, the coagulopathy, the ovulatory dysfunction, right? Now based on this clinical profile, which differential diagnosis should I put up as the first choice? Yes, which differential diagnosis should I put up as the first choice? So the structural causes are more likely. The structural causes are more likely, right? Since the cycles are regular, heavy menstrual bleeding is there, congestive dysmenorrhea is there, I would like to think in terms of adenomyosis. It could be a leiomyomas, right? Fibroid could be there so far, right? And ovulatory cycles are less likely because her cycles are regular, right? It could be a coagulopathy. I will have to take history regarding that as well. And other than that, the other important differential diagnosis I'm considering is because of the fact that she has congestive dysmenorrhea. She could be having endometriosis also. She could be having endometriosis also because of the severe congestive dysmenorrhea. But endometriosis is way down in my list of differential diagnosis because endometriosis will not likely have heavy menstrual bleeding. And on the other hand, endometriosis will also have infertility. So this woman is multiparous. She's 45-year-old. So that makes endometriosis slightly less likely. But yes, it could be there, right? So I'm considering all of these differential diagnoses, right? So I further take the history forwards. So what I do note, I note that there is no history of postcoital bleeding or intermenstrual bleeding. So I will have to ask her that, right? So that goes against the diagnosis of polyps or endometrial polyps or submucous fibroid polyps. So that is what it is pointing to. There is no history of dyspareunia. There is no history of painful intercourse, right? So if she had endometriosis, she would have painful intercourse as well. So dyspareunia is not there. There's no history of vaginal discharge. I mean, painful periods could be because of PID as well, pelvic inflammatory disease as well. So there is no history of vaginal discharge. And simply pain in the lower abdomen could be because of urinary tract infection also. I mean, that should be kept in mind as well. So there are no urinary or bowel complaints as well, right? So no urinary and bowel symptoms that could explain her pelvic pain. Another important point is that she has said in her history that her complaint has been there for 3 to 4 years. That means obviously she must have sought some medical intervention in those 3 to 4 years. She must have visited somebody. So, treatment history for what happened during those 3 to 4 years is also important. So, she tells you that she has tried oral contraceptive pills in the past, but she was not relieved. You ask her, did she try anything else apart from oral contraceptive pills? She says that she was also started on medroxyprogesterone acetate or some oral progesterone treatment. She was not relieved, and so she discontinued the medication. Now, what does this history tells you? What does this history tells you? Yes, what does this history tells you? This history tells you, very, very importantly, that there is a condition. She is suffering from a condition which is not responding to the traditional modes of treatment for abnormal uterine bleeding. Oral contraceptive pills have been tried, she is not responding. Medroxyprogesterone has been tried, she is not responding, and she is not relieved. Now, if she had endometriosis, she would slightly be relieved with oral contraceptive pills, right? She would slightly be relieved of her symptoms with medroxyprogesterone acetate as well, right? So the fact that conventional treatment is not working in her points towards the possibility of a condition which is not responding to your normal treatment, usual treatment. And adenomyosis is notorious in that regard. Adenomyosis is notorious in that regard, in that it fails to respond to oral contraceptive pill treatment. It fails to respond to progesterone oral treatment most of the times, right? So that is very, very important history point to note here, right? More than that, if she would have had anovulatory cycles, or if she would have had a dysfunctional uterine bleeding, or if she would have had a hormonal imbalance which is responsible for her abnormal uterine bleeding, I mean, that would also have responded to a trial of oral contraceptive pill treatment or a medroxyprogesterone treatment. So prior treatment history again is very, very important in this situation. Now, moving on further, past medical and surgical history for her is unremarkable. I mean, she's not taking any drugs which could have led to her abnormal uterine bleeding. There is no history of any other surgery or any other prior surgery for any gynae condition which could make you think in terms of a recurrence of a situation. So, fibroids are known to recur, right? So, there's no past medical or surgical history relevant to this particular case. Now, moving ahead with the clinical examination. Now, what did we find? We found that she looks pale and distressed. I mean, her complaint has been going on for 3 to 4 years. So she's looking pale, she's anemic, and she's also very distressed with her complaint. Her pulse rate is 86 per minute, BP is 120/72. Let's say her cardiorespiratory system examination, a general physical examination is otherwise normal. Thyroid and breast exam is normal. Per abdomen is soft. There is no lump palpable. There is no tenderness also there. Per speculum examination, cervix and vagina is healthy, so there is no cervical cancer there. There's no growth on the cervix there. There's no polyp, which explains her symptoms. So that is there. So per abdomen, per speculum examination, unremarkable. PV is what is going to clinch your diagnosis here. So on per vaginal examination, you find that the uterus is enlarged to about 12 weeks in size. It's globular, it's tender, and it's mobile, and your bilateral fornices are free and tender, right? Non-tender, free and non-tender. So the uterus is enlarged, yes, globular and tender and mobile. That points more in favor of adenomyosis than anything else. I mean, uterus can be enlarged even in a fibroid. But in a fibroid, the uterus that will be enlarged can be irregularly enlarged, but most likely in a case of fibroid, the uterus is going to be irregularly enlarged. It is going to feel firm. It is going to be non-tender, right? Whereas in the case of adenomyosis, the uterus is enlarged, it's globular, it's tender, it's also soft and spongy to feel. It is soft to feel. So all of these things point towards the diagnosis in favor of adenomyosis rather than fibroid. So when you get a case in the examination, when you are presenting a woman with abnormal uterine bleeding and you're talking about the differential diagnosis, the main important point that your examiner wants to ask you is, how do you differentiate between adenomyosis and fibroid uterus based on the history, based on the clinical examination, and based on the other investigations that we are going to perform. So that is a very key important viva question that examiners often ask you, right? So you don't jump into investigation straight away. What you answer is that I will take a history. On history, a patient with fibroid uterus will not have, unlikely to have pain, only heavy menstrual bleeding. On history, a patient with adenomyosis will complain of heavy menstrual bleeding plus dysmenorrhea. That is one clinching factor. Second, you'll say that I will look for the examination findings, and that I have highlighted in front of you how to differentiate between adenomyosis versus fibroid. Now then, what would be your next step in the examination? What is your next step going to be? What investigation do you want to do? What is the investigation you want to do in this particular case? I have two arrows pointed out for you. So what are the investigations that we would like to do now in this particular case, guys? Since she's looking pale, her condition has been there for 3 to 4 years, it would be a good thing to check for the CBC. I want the HP and I want the platelet count. And the next investigation would be a simple ultrasound. Next investigation would be a simple ultrasound, right? CBC and simple ultrasound. Now, what am I going to find on this ultrasound? Let's have a look at that. Now, the ultrasound picture is shown in the figure here. Now, let us describe them one by one. What do we see? We see that that's your entire uterus outline. And the findings tells you that it is a bulky uterus with a thickened posterior wall. So this is your anterior wall of the uterus and that's your posterior wall of the uterus, right? So thickened posterior wall. Now most of the times the uterus is globular, enlarged, with a predominance of thickness being in the limited to the posterior wall. There is loss of endomyometrial junction, right? That means where the endometrium begins, where it ends, where the myometrium begins, that junction between the endometrium and myometrium is not clearly delineated on the ultrasound. So there's loss of endomyometrial junction and presence of myometrial cysts. So you can see here, you can see these round hypoechoic areas. These are small myometrial cysts which can be seen. So presence of myometrial cysts is also there in this ultrasound. And the other thing that you can appreciate, I mean, this is myometrial cysts here also, that dark areas rounded that I have outlined for you. Other than that, in this particular, you see there's this it looks like as if the sunlight, as if rays of sunlight, these white lines, you have those blinds on the curtain. Now this is sometimes described as the Venetian blind appearance that you can see on the ultrasound. So this can also be seen there. So these are your ultrasound findings here. The other finding is that the endometrial thickness is 12 mm. Bilateral ovaries are normal. So these are your findings. Out of all these findings, the most specific finding is the presence of myometrial cysts. Now, Shrigiri, myometrial cysts are just the appearance of the endometriotic deposits. When you see on ultrasound, when you do an ultrasound, the basic principle of ultrasound is how the ultrasonic waves are reflected from the tissue surfaces, right? So there are deposits inside the myometrium. So the homogeneity of the myometrium is disturbed and these deposits give the appearance of myometrial cysts, right? So that is how they are described as on ultrasound. They are the most specific finding on a usual grayscale ultrasound. So I have an inset here. You can see on the figure, this is a normal ultrasound. right? So you can see here how beautifully the endometrium is delineated. You can see this thick line in the center, and this here is your myometrium. You can clearly see the junction between the endometrium and the myometrium. Now in this ultrasound, you can't appreciate that, right? So all of these findings are suggestive of, again, adenomyosis, and you have a very specific finding also, which is myometrial cysts. So based on her clinical history, based on her examination findings, and further corroborated by a routine ultrasound, a normal grayscale ultrasound, I can, with certain confidence say that this is adenomyosis and nothing else, right? Now, moving on further, I got this response here from somebody. Dr. Sadam, you said baseline investigation is definitely an ultrasound, and your gold standard is MRI. True, true that. Gold standard investigation is MRI. But the whole question is whether such an expensive investigation in this particular case, in which our woman is 45-year-old, clinical symptomatology so accurately described, and your ultrasound findings are highly suggestive, and you have a very, very specific finding that, like that of myometrial cyst present, do we always need to go ahead and do the gold standard test? Now that's the question I want to raise. What is the next step? Do you order an MRI to confirm the diagnosis? I mean, is it really required to do an expensive investigation like MRI when it might not change the course of management? Do you schedule for a hysterectomy straight away? What are the treatment options left? Since she's already tried oral contraceptive pills and oral progesterone treatment? And the next question that I want to raise is, if at all there is one investigation which is most important that would be required before deciding on a definitive course of management, what that investigation would be, right? So yes, guys, what do you think? Do you order an MRI to confirm diagnosis in this particular woman? Now let's say I did order an MRI, and these are the findings that I can see on MRI. So this is the uterus here, this is your anterior myometrium, this is your posterior myometrium, which is quite thickened, this is your endometrial shadow in the center on MRI, and these white arrows are pointing towards this thick area. Can you see here? This is slightly darker, blacker than the surrounding outer myometrium. So this is your inner myometrium. This dark area here is your darker inner myometrium, right? Now this has enlarged, this has thickened. So this thickening of the inner myometrium, which we appreciate on the MRI, is what we call as the thickness. We measure the thickness of the junctional zone, right? So I told you in the very beginning that around the deposits of endometrial tissue there is myometrial hyperplasia, which leads to the thickening of the inner myometrium, and when we measure it, we call it as the junctional zone. We measure it on the MRI. Now, if the thickness of the junctional zone is more than 12 mm, it confirms the diagnosis. If the thickness of this junctional zone is less than 8 mm, it rules out the diagnosis for adenomyosis. Now, between 8 to 12 mm, again, is a gray zone where we don't know, where we are not certain, right? So MRI is definitely the gold standard and is definitely better than ultrasound to find adenomyosis. But how clinically relevant it is in my particular case, how clinical relevant it is. So yes, guys, Dr. Sanam, you're rightly saying that if your ultrasound is suspicious, and it is not giving clear-cut findings, I mean, then of course one would go ahead and order an MRI. But in my particular case, I don't need an MRI to make the diagnosis. The clinical profile, the physical examination findings, and the ultrasound is enough to make the diagnosis in that situation. So in my particular case, do I order an MRI to confirm the diagnosis? I said not required, because of the very, very important fact of the clinical findings and the physical examination findings, and the ultrasound is quite corroboratory. Do you schedule a hysterectomy straight away? Yes or no? Do you schedule a hysterectomy straight away, or you will also factor into consideration what the woman wants? I mean, you will have to discuss the treatment options with her, isn't it? You will have to discuss the treatment options left with her, right? So, what are the treatment options left with her? Yes, guys. What are the treatment options left with her? What are the treatment options left with her? So, do you schedule a hysterectomy right away? No. I want to first discuss the treatment options left with her. So, what are the treatment options left with her? Yes, of course, there is a definitive surgical management. Definitive hysterectomy is one treatment option for her. It's not myomectomy. There's no myoma there. There is no myoma there, but yes, there is a potential for medical management. There is definitely a potential for medical management in the form of Mirena insertion, right? Progesterone therapy in the form of Mirena insertion, levonorgestrel containing IUD, or GnRH analogs. These are all because GnRH analogs are going to suppress the ovaries. They are going to stop the ovaries from synthesizing estrogen, right? And adenomyosis, just like any other fibroid condition, are these endometrial deposits inside the myometrium. They respond to estrogen in the same way that normal endometrium does. So when GnRH analogs are going to be used, then the woman becomes amenorrheic, and then she gets relieved of her symptoms completely with adenomyosis also. But then there is a limitation to the use of GnRH analogs because, of course, they produce menopausal-like symptoms, predisposed to osteoporosis, and I can't use them for more than 6 months at a stretch. So these are alternative treatments available in case she wants to conserve her uterus, in case she wants to have future childbearing. I mean, what do I know? She is multiparous, but she might want to conceive again. So yes, of course, medical management options need to be discussed with her. What she wants, does she wants to conserve her uterus, future childbearing or not, right? And if that's not an issue, well, of course, the definitive management is surgery or hysterectomy. Right? Now, the next question is, what investigation would you like to perform before deciding on a definitive course of action? Now, let me just summarize the case for you here. 45-year-old multiparous, heavy menstrual bleeding with severe congestive dysmenorrhea for 4 years, ultrasounds suggestive of adenomyosis, mild anemia. What is the next investigation which I would like to do or you would like to do before taking up for her hysterectomy? Let's say she chooses more in favor of hysterectomy. What can be done? Yes, guys. Is there any other investigation which you want to do before deciding on a final hysterectomy, before taking a call on hysterectomy versus medical management, before doing that? Any other investigation? Yes, guys. So Dr. Sanam is answering their endometrial biopsy. Very good, Dr. Sanam. So and you see here that this is a woman who has clinically symptoms suggestive of adenomyosis, right? But all during the reproductive age group. The fact here is that she is 45-year-old. She is more than 40-year-old. She could have endometrial hyperplasia. What if that hyperplasia is atypical hyperplasia? Then that would change the course of management. Then I would not like to offer medical management in the first place, right? So endometrial biopsy is one investigation which has the potential for changing the management. And yes, do not say if that the ultrasound is showing features of adenomyosis, then that means that there cannot be endometrial hyperplasia, that there cannot be an underlying endometrial cancer. So before offering conservative management which deals with retaining the uterus, you see, you have to rule out hyperplasias and cancer. So you have to perform premenstrual endometrial aspiration. Very good. So the investigation that has the potential for changing the management is endometrial biopsy, and you perform that using endometrial aspiration technique. You send the endometrial tissue for histopath, and now the histopath reveals a secretory endometrium. And now you can decide whether you want to go for a Mirena insertion or a GnRH analog therapy or a hysterectomy. So the woman was counseled regarding both, and the woman and the doctor decided together that hysterectomy is the best option for this woman. She says that no, I want a one-time therapy. I don't want Mirena insertion. I have tried enough treatment already. I've been troubled by this for 4 years of my life. I want a definitive one-time treatment. And yes, that in that case, it is justified to do a hysterectomy. But please don't answer adenomyosis, young women. Let's say, for example, she's nulliparous. If she's nulliparous, then I will not, and if she wants future childbearing, then I will not offer her hysterectomy as an alternative therapy. I will not offer hysterectomy as a treatment option for that woman. If she's a young woman, I will not offer hysterectomy as a treatment option for her. So again, the decision to do a hysterectomy will be based upon the age of the woman, the reproductive desires of the woman, and then after that, the clinical profile as well. In this particular case, she's 45-year-old, she's multiparous. So yes, of course, she can choose hysterectomy as a treatment option as well. And I would be more tilted in offering her a hysterectomy because of the fact that she has tried other treatments and that has not worked prior to that in the last 3 to 4 years. Okay, now let's say she did undergo a total laparoscopic hysterectomy and the specimen is shown below, and this is your specimen here. So can you see the difference between the specimen of a fibroid and can you see the difference between the specimen of an adenomyosis uterus? I mean, if this figure was given to you, would you be able to identify it as adenomyosis? Can you see that there are no whorled tumorous growths which we can see here? No whorled tumorous growths which we can see here, but we can see a diffuse enlargement of the myometrium. That is what we are seeing. So based on this gross specimen report, so this is your gross specimen, it does look like adenomyosis. But is that the only confirmation, or I should do something else? Is that the only confirmation, or I should do something else? I mean, what is done after every surgery? After every surgery, whatever is taken out from the body is definitely sent for histopathological confirmation, isn't it? Right? So I'm going to send this specimen, gross specimen, for histopathology. And now the histopathologist is going to cut up slices of this specimen and then going to observe the specimen under the microscope. And finally, it will be the histopathologist who will give me the report that yes, indeed, the histopathology of the specimen showed that there is presence of endometrial glands and stroma. See, the glands and stroma of the endometrium are found deep within the junctional zone. They are found at least more than one high power field deep to the junctional zone. So these are the myometrium fibrils that you can see. And interspersed in between the myometrium are endometrial glands and stroma. So the ultimate 100% confirmation of adenomyosis is going to be finally by histopath. But not histopath of the endometrium, guys. Not histopath of the endometrium. You can't diagnose adenomyosis on histopathology from an endometrial aspiration technique. But it has to be a histopath from a hysterectomized specimen. That doesn't mean that you have to resort to a hysterectomy every time to diagnose adenomyosis. And this is the clinical scenario. This is how women with adenomyosis are going to present, how they are going to be suspected, how they are going to be worked up, right? And then finally, in this particular case, the final 100% diagnosis was based after the hysterectomy specimen was analyzed histopathologically, right? Okay. Now, Dr. Sanam, you want to describe the junctional zone of the uterus. The junctional zone is nothing but the inner myometrium. Okay, so here let's say if you have this here would be the junctional zone. This here would be the junctional zone, the inner myometrium. I mean, the uterus has been cut in half. Okay, so inner myometrium is the junctional zone because around these endometrial tissue deposits, there is myometrial hyperplasia. Because of that myometrial hyperplasia, the thickness of the junctional zone increases, and it is this thickness of the junctional zone, which we can appreciate on the MRI. Now, the junctional zone is going to look slightly darker, blacker than the surrounding peripheral myometrium or this outer myometrium. So, we can measure the thickness of this junctional zone on MRI. So, that is what is junctional zone. Inner myometrium, where the myometrial hyperplasia is taking place. Okay, Dr. Sanam? So this was a short case, guys. This was a short case, guys. Any further doubts and queries regarding the workup of abnormal uterine bleeding and adenomyosis case? So what you need to appreciate is just salient points here. Whenever a woman comes with the complaint of heavy menstrual bleeding, you have to differentiate whether it is a fibroid or whether it is an adenomyosis. That is an often asked question, right? So you will differentiate this based on the clinical history. You will base your decision based on the physical examination findings. And finally, your first line investigation is going to be an ultrasound. Right? On ultrasound, if it's a fibroid, it can be clearly seen. Adenomyosis findings on ultrasound I have described to you. If you are suspecting adenomyosis based on history and clinical examination and your ultrasound is inconclusive and you have a strong suspicion for the presence of adenomyosis, you can go ahead and get an MRI done. It's not always necessary. It will depend from case to case basis. And the other important thing to note here is that do not forget the other differential diagnoses which we talked about yesterday, Palm and Cohen, and all of these differential diagnoses can be ruled out by simple history taking and examination findings as well, right? So Shrigiri, one last time, fibroid versus adenomyosis. Clinical history, one side fibroid, one side adenomyosis. Fibroid, heavy menstrual bleeding is going to be the predominant complaint. Pain is unusual, right? Pain is unusual, usually not there unless and until there is torsion or there is sarcomatous degeneration or there's red degeneration. We've considered this yesterday. And fibroid itself can also lead to pressure symptoms, can lead to other kind of problems that could contribute to infertility, but then clinical presentation is different. I'm talking about a case with history of heavy menstrual bleeding. Adenomyosis, heavy menstrual bleeding plus severe congestive dysmenorrhea. Right? Examination findings. Both of the cases can have enlarged uterus, but in fibroid, the uterus is going to be irregularly enlarged. It is going to be firm to feel. It is going to be non-tender. Adenomyosis, a diffusely enlarged uterus, right? It is going to be globular. It is going to be tender. It is going to be soft to feel. All right, so these are your clinical history and examination findings as far as fibroid versus adenomyosis are concerned. Next line investigation, a simple ultrasound. After the ultrasound, you would have found features of fibroid or adenomyosis. And it is also common, guys, it is also possible that you can find a small fibroid also associated with an adenomyosis together. And then you have to, yes, rely on MRI. So if your findings are inconclusive or your clinical history is not aligned with your ultrasound findings, then of course you can go ahead and confirm with an MRI. Okay. Now, Mehak, why posterior cervical fibroid leads to urinary retention? You see, this question has always been asked, and I honestly have not found any text, particularly standard text, which would say that it is always the posterior cervical fibroid which leads to urinary retention. You see, I will try to tell you that it is by virtue of the fibroid size and the location that it is going to cause symptoms. You see, let us just understand here it by an anatomy, by a diagram. Okay, so that's your urethra, that's your bladder, that's your vagina, and that's your cervix here, and whatever, uterus above, right? So they are saying that a posterior cervical fibroid is going to cause urinary retention. Okay, I don't deny that if the posterior cervical fibroid is large enough to compress the urethra, it will cause. See, when a cervical fibroid is going to originate from the posterior cervix, you see, posterior cervix, it is going to enlarge, it is going to fill up the vagina. Only then will it will be able to compress the urethra. On the other hand, if it's an anterior fibroid, let's say if there is an anterior cervical fibroid, right, even an anterior cervical fibroid, if large enough, has capability of compressing the urethra and leading to urinary retention. So both posterior and cervical fibroids can cause urinary retention, right? But yes, if it's a small cervical fibroid, let's say if it is a small cervical fibroid and an anterior cervical fibroid, here a small anterior cervical fibroid, right? Now before it causes compression of the urethra, it is going to cause irritation of the bladder and urethra in front. So anterior cervical fibroid, which I feel should more likely cause urinary frequency or urgency first, before it becomes large enough to cause urethral compression. If it is going to become large enough, it is going to cause urinary retention, urethral compression, and then it is going to cause urinary retention. Whereas a posterior cervical fibroid, on the other hand, since it is not irritating the urethra or bladder initially, it does not lead to urinary frequency and urgency. So a posterior fibroid is more likely to cause a urinary retention. But for that, it has to be big enough and large enough to ultimately cause urethral compression, right? So that is how I understand it. Okay. And now, other question here, Dr. Sanam, posterior cervical fibroid, rectum more likely? Yes, it can lead to irritation of the rectum, and it can lead to a woman complaining of pain during defecation. It can lead to complaint of constipation, maybe. Yes, that is a potential there, right? Now, Vishnu, about the biopsy on ruling out endometrial hyperplasia. What do you want to know about the biopsy and ruling out endometrial hyperplasia? It has to be done. Woman company coming with the complaint of abnormal uterine bleeding, any pattern of abnormal uterine bleeding, and she is more than 40 years of age, before starting any treatment, whether hormonal, non-hormonal, medical or surgical, always go for endometrial aspiration to rule out hyperplasia and endometrial cancer. And you can do it even earlier. That means less than 40 years also you will be doing, if there are risk factors for endometrial hyperplasia and cancer. Like for example, if you have a 35 year old who's obese also, who's hypertensive also, who's diabetic also. Now this particular woman, or let's say for example she's having 35-year-old obese, hypertensive, diabetic, and history of prolonged anovulatory cycles. Now this woman is more likely for having endometrial hyperplasia or endometrial cancer. So in her, because she has all of these risk factors, I would like to do endometrial aspiration even though she's only 35 years of age, right? So I can do it earlier if there are risk factors for endometrial hyperplasia or cancer present. Otherwise, any woman who's complaining with any complaint of any pattern of abnormal uterine bleeding and she's more than 40 years of age, it is mandatory to perform an endometrial aspiration before embarking on any progesterone therapy or oral contraceptive pill therapy or any conservative therapy versus a surgical therapy, because this one investigation has the potential to change the management course or the treatment course. Okay. Now, what else? Lakshmi, effects of adenomyosis in fetus in cases of pregnancy. See, sometimes it has been seen, sometimes it has been suggested that with adenomyosis and pregnancy, the placental developmental can be hampered, the decidual development can be hampered, and then because of that reason, there is increased risk of having growth restriction, increased risk of having abortions. But those are not a very substantiated. This randomized control trials are lacking for that, because you see, so far the adenomyosis has been much more common in already multiparous women. So that's why I don't have a very clear cut response to that question of yours. But yes, likely complications are possibly that of growth restriction, abortions, or ineffective placental development and its consequences, or for that matter, postpartum hemorrhage after the delivery of the baby, because the contractility of the uterus is affected. So these are potential complications in case of pregnancy with adenomyosis. Okay, Lakshmi. And then we have a question. Aisha Nikhat, how Mirena helps in fibroids and adenomyosis? That's a very good question. Let me tell you about that here as well. So, how Mirena is helpful in cases of fibroids and adenomyosis, because basically Mirena basically more or less provides symptomatic relief. It provides symptomatic relief because it thins the endometrium so much that it most of the time decreases heavy menstrual bleeding, because it thins the endometrium. Sometimes it is so effective in thinning the endometrium that a woman who's been using Mirena for a year or two, most of the times they are going to have amenorrhea as well, because the endometrium is very thin. So it provides mainly symptomatic relief, no bleeding, no pain, and therefore the woman gets symptomatic relief. She gets to conserve her uterus also. That's how it is helpful. But please remember, again, one more pointer I would want to say, that if you have a fibroid like this, if you have a fibroid like this, then you can't insert Mirena. Mirena is also T-shaped device. If your cavity of the uterus is distorted, then introducing Mirena and fitting Mirena is problematic, right? So Mirena in case of fibroids can be inserted if your endometrial cavity is not distorted. It is not distorted. Okay, but Mirena basically provides symptomatic relief. Okay, and the other reason why Mirena also works is because of the progesterone. Because of the progesterone, right? So the progesterone, see, all of these fibroids growth is again estrogen dependent. The growth of the adenomyosis is also estrogen dependent. Now progesterone counteracts the effect of estrogen as well. So that is another reason why Mirena helps. Okay, that is another reason why Mirena helps. So there are two reasons: symptomatic relief, and the other reason, as Sanam pointed out, that all these progesterone, how progesterone has the potential for providing relief is that it is going to counteract the effect of estrogen. That's how. Now, Lakshmi, what about the different types of degenerations in the fibroid? Now, if we had covered that yesterday also. We'd covered the degenerations of fibroid yesterday as well. If you want me to repeat them again, there are various kinds of degenerations in fibroid. Hyaline degeneration is the most common type of degeneration in a fibroid, and we've talked about that yesterday as well, that your fibroid takes its vascularity from the periphery, right? Fibroid takes its vascularity from the periphery, and your center of the fibroid is the least vascular part. So any necrosis that has to happen, will happen in the center of the fibroid, and any hyaline deposition will have to happen. It can happen. Your fatty deposition can happen, right? So it is these are basically degenerations are basically be found in long standing fibroids, and fibroids which have been there for a very long time for that, and fibroids which which are rapidly growing in size, fibroids which are rapidly growing in size, because then the fibroids are competing with the vascularity from the rest of the myometrium as well. So you can have hyaline degeneration, fatty degeneration, calcareous degeneration. I mean, your calcium can get deposited in the periphery of the fibroids as well. So these degenerations are otherwise of no important clinical significance. I mean, they're not changing the management in any way. They're not changing the management in any way. They're not affecting the symptomatology in any way. So the other degeneration is the red degeneration, which is seen during pregnancy, and the other degeneration is sarcomatous degeneration, which is again extremely rare, and if at all this degeneration happens, it will happen in post-menopausal women. And sarcomatous degeneration is associated with the fibroid rapidly increasing in size, and with a fibroid which starts becoming painful or symptomatic in a post-menopausal woman. So these are the degenerations. And Mirena does not decrease the size of the uterus, no Sanam. Mirena is only a drug delivery system. Mirena Sanam is only a drug delivery system. It is somebody who's taking medroxyprogesterone orally. Now I'm giving progesterone directly into the uterine cavity, isn't it? So levonorgestrel I'm giving the same drug. So it doesn't decrease the size of the uterus. Okay. Dr. Sanam, hyaline degeneration is the most common. Red degeneration is particularly happening in pregnancy. It's particularly happening in pregnancy in the second trimester. Now see, there is a particular reason why it is also called as the red degeneration. You know, why is it called the red degeneration? It is an aseptic degeneration. It is an aseptic degeneration, and it is also, there is no infection which is happening in red degeneration. So what is this red degeneration, by the way, if I will tell you? If I were to tell you, let me tell you, just talk about this red degeneration here a bit. Well, most of the times it is seen confined to, mostly it happens during pregnancy, and mostly it happens in the second trimester. Now, have you ever wondered why in the second trimester? Have you ever wondered why in the second trimester? I mean, why not in the first trimester? Why not in the third trimester? Why in the second trimester? Why? Because see, that's your uterus here. That's your uterus here. This is your 12-week size uterus. And that's your uterus here 16 weeks. That's your uterus here 20 weeks. So you see what is happening in the second trimester. A dramatic increase in the size of the uterus is happening in the second trimester. What else is happening in pregnancy? Blood flow through the uterine arteries to the uterus is increasing. There is excessive blood flow into the uterus. Right? And there is excessive increase in, right, a dramatic increase in size of the uterus when the second trimester sets in. Right? Now, all this increased blood supply which is taking place in pregnancy is going to take care of the placenta. It is going to take care of the rest of the myometrium, but there is also fibroid here. There is also a fibroid here. So let us just say that this is a fibroid which is competing for blood with the rest of the myometrium. There is myometrial hyperplasia, hypertrophy that is taking place during pregnancy. There is another placenta which is attached here, which is taking all this blood flow. So this fibroid, I would describe it as, this fibroid is deficient. This fibroid is deficient of blood supply in plenty. Deficient in plenty. There's a lot of increase in blood flow that is happening to the uterus, but yet the fibroid is deficient in blood supply, right? So that makes the fibroid mass ischemic, and that predisposes to degeneration of the fibroid. Now that is called as red degeneration. Why red? Red because there's a lot of vascularity in the rest of the rest of the uterus. So it is deficient of blood supply in plenty. That is how I would like to describe it. So on one hand, high vascularity. right? Even that high vascularity, the fibroid is deficient, and that is causing necrosis, that is releasing inflammatory mediators, making the fibroid tumor ischemic, releasing inflammatory mediators. Those inflammatory mediators are triggering the response by the body: nausea, vomiting, slight fever, slight increase in TLC count, slight fever, slight increase in TLC count. That doesn't mean that the woman is having infection, right? Okay, so that's why it is most commonly seen in the second trimester. Now, that's your etiology of red degeneration. It is mostly confined to pregnancy, because pregnancy is one time where the vascularity of the uterus increases. Any other condition which the vascularity of the uterus might increase, I mean, that condition can also lead to red degeneration, but such condition is pregnancy. Such common condition is pregnancy, right? Okay. Any other doubts regarding I think by the end of these two sessions, we have discussed a lot about fibroids and adenomyosis. Now, fibroids is such a huge and a varied topic. I mean, you can find fibroid with women complaining of abnormal uterine bleeding. Then you can find them with women who are complaining of infertility. You can find them in women who are complaining of pressure symptoms and whatnot. I mean, so yes, fibroid is a very varied topic. Since they're so common, it is very common to identify fibroids in women who are pregnant, and so many times, because they're actually very common, and pregnancy is one opportunity when ultrasounds are performed on the woman. So many times fibroids which have not been identified earlier, women might have been asymptomatic with it, and they're picked up for the first time during a pregnancy scan only. But then there's nothing to worry with those fibroids. You see, I mean, the woman has happened to conceive and carry on a pregnancy with fibroid without undergoing red degeneration or any of the complications which a fibroid can create. But yes, a fibroid is more likely to cause problems if they are multiple, if they are large in size, and if there's small fibroids sitting inside the uterine myometrium, most of the times they're not going to cause any problems at all. Okay. Chalo guys, so thank you so much, and let me tell you again, 29th of November, 8 p.m. I will be talking about vulval cancer. For NEET PG aspirants, vulval cancer is emerging as a hot topic. In the last two exams, vulval cancer was not commonly asked in NEET PG. For years they were silent about vulval cancer, but yes, in the last two exams they have framed questions on vulval cancer. So we will be discussing this on the special free live class on 29th of November. That's tomorrow, 8 p.m. You can also find the other plus classes, and you can these are free and you can access them. These are the recorded versions. You can watch them at the comfort of your own choosing and time and everything, so you can watch them. You can welcome all of your suggestions regarding these classes as well. Once you subscribe to the plus course using the referral code here, that will help you avail a 10% discount. You can access the courses in reproductive gynecology, high-risk pregnancy, gynae-oncology, and there's a complete capsule course on labor and its complications as well. So you can check that out as well. And for any further suggestions, you can put them down on the chat box. I'll be reading them. So thank you guys so much. Bye-bye. Take care. Have a great day. Subscribe to the platform. Keep learning and keep discussing. And that is the way to go about it. Bye-bye, guys. Take care. Thank you so much.